You've been asked to come and review a patient who is very hot and very agitated, and by very hot we mean temperature well above 38 degrees Celsius. How do you know what is causing it based on the history and the examination? Usually you can get enough information over the phone before you see the patient to work out in your own mind what's going on, and then you can just confirm this when you see the patient yourself. And we've built this flowchart for you to work through. So start by asking, is the patient really sweaty? Because if they are hot and not sweaty, there's only really one thing this can be, and this is an anticholinergic syndrome. Classically associated with antihistamines, tricyclic antidepressants, some Parkinson's meds, and skeletal muscle relaxants, and some plants like deadly nightshade or atropine, they will cause this toxidrome, and it's characteristically hot and dry. So that's the first one to branch off the flowchart. If they are sweaty, then ask if they are very rigid. If they are not very rigid, then it's most likely a sympathomimetic condition. So this is excessive catecholamines or adrenaline, usually released by illicit recreational drugs like cocaine, methamphetamine, MDMA. It can also be triggered by theophylline if a patient has had lots and lots of treatment for their asthma or their COPD. If they are hot and sweaty and they are demonstrating rigidity, a very easy next filter is, have they recently had any volatile or inhaled anesthesia or succinylcholine? If so, this is a classic history of malignant hyperthermia. This is very unlikely to be in the emergency department. It's much more likely to be in theatre. So if you've got a patient who's got a rapidly rising temperature and CO2 and they're very rigid, this is a classic history of malignant hyperthermia. But this is unlikely anywhere else in the hospital other than in theatres. So let's say they're very hot, they're sweaty, they are demonstrating rigidity, and they've not recently had volatile anesthesia or succinylcholine. Then you ask, have they got hyperreflexia and clonus? Clonus is an involuntary, rhythmic, and repetitive muscle contraction, and it's an upper motor neuron sign. So classically what you do, you put sudden upward pressure on the ball of the foot, and the ankle will contract rhythmically and involuntarily. That is clonus. So if they've got hyperreflexia, very brisk reflexes, and clonus, then this is almost certainly serotonin syndrome, and they must have taken some drug that affects serotonin in the last few hours if it's going to be serotonin syndrome. And if they don't have hyperreflexia or clonus and they're just stiff, call it lead pipe rigidity, they're just very stiff, this is neuroleptic malignant syndrome. And crucially, they must have taken a drug affecting dopamine pathways, but usually this is much slower onset. You're usually looking at a few days after a significant change. Either they've started a dopamine inhibitor, such as an antipsychotic, or they've suddenly stopped a dopamine agonist, such as a Parkinson's medication. Now, each of these will warrant a full description and a video by themselves, but if you know enough about each of these conditions to be able to start treating them, then this flowchart should help you work out which one you're targeting while you're on the way to see the patient.